It's nighttime, and you're just getting off your clinic duties. Today, there were 12 patients who you saw over the phone. 2 of those patients required you to actually go into the parking lot to do a physical examination. As you were leaving the office today, you get a call from the charge nurse at the hospital. A 66-year-old patient of yours with obesity and chronic renal failure was just admitted to the hospital. However, he only lasted 2 hours. You go to the hospital to pronounce death and realize that he had presented to the emergency department with a severe respiratory illness. You know that he didn't typically have any respiratory problems. He was managing his chronic renal failure with dialysis and was doing fairly well. This was a complete surprise. So, you make a call to Erik Christensen, the state medical examiner, to ask him if he's interested in taking a look. This could be a possible coronavirus case. Welcome to our new podcast. We have the wonderful pleasure of interviewing Erik D. Christensen. He is a graduate of Brigham Young University, so right here in Utah. He did a categorical pediatric internship in the Army, actually. Then he spent 3 years as a general medical officer and a flight surgeon, and he's got tons of experience. So then after doing that, he then did a residency in anatomic and clinical pathology at Madigan Army Medical Center in Tacoma, Washington. He was then the director of the Autopsy service. After working for a while in South Carolina, we now have the privilege of having him to be our state medical examiner for Utah. And he's been in that role of the chief medical examiner since 2016. Really, we can take a lot of appreciation in what he has been doing for us, and especially given this time with the COVID-19 epidemic. My name is Scott Moore. I'm a physician, a pathologist as well, and I teach medical laboratory sciences at Weber State University. And I will be interviewing with Petronella Adomako. Petronella, would you like to introduce yourself?
Hi, I'm Petronella Adomako. I am an infectious disease doctor over at McKay Hospital in Ogden, Utah, and I am the president of the Ogden Surgical-Medical Society for the year 2020. But courtesy of COVID, I get to extend it one more year. Nice to talk to you, Dr. Christensen.
Thank you. It's good to be here.
Dr. Christensen, I was reading through your biography and reading through kind of some cases that you have, and you know, I love that that we get to interview another pathologist. It's not very often that you know, those of us in one of the smallest specialties of medicine get to interact.
It's true.
Yeah. And so I do appreciate this. I was also really kind of thrown aback by the opportunity to discuss COVID-19 and its influence on, you know, autopsy practice. My first question is, you know, what has the effect on the caseload been?
So I guess it's a little bit of a twofold question. So for our office, we are only involved in doing autopsies in cases that fall under our jurisdiction by state law under the Utah Medical Examiner Act. And that does include deaths due to diseases that are concerns to public health, which clearly coronavirus infection falls under that. You know, the statute simply mandates what kind of things have to be reported to us, and then we determine what we need to do in terms of the examinations. And so most of the cases of coronavirus, most known cases that result in death, are not coming to our office. They're still reported to us. They get assigned a case number, and I am reviewing all of those death certificates and just you know, reviewing to make sure that they conform to our guidance we've received from the National Center for Health Statistics. But we're, you know, essentially not examining most of those people. There are a number of people that are still coming into our office for either testing and or autopsy. For example, in a case where you know, someone has an ill family member that, say, tested positive for coronavirus, and the other person gets sick and may die but had never been tested. Those kinds of cases are coming to us for testing and/or examination, depending on the nature of their criminal course. We have been for over a month been testing everybody that comes through our office, regardless of their perceived cause of death, just to kind of have background surveillance on what's going on in our case population. But our caseloads overall, I mean, we're on pace to be up almost 10% this year, even after excluding all the jurisdictional COVID cases that aren't coming to the office. And so some of it is because we're bringing in people that we might not otherwise bring in to do that kind of testing. We are not seeing increases in wide swaths of other types of deaths. We're not seeing a huge increase in suicides. We're not seeing a huge increase in drug overdoses, which are probably the two most prevalent things in our practice. But it's still relatively early on in our information gathering about what's gone on, since all of this began in Utah. So, but there's no question our caseload is up.
Dr. Christensen, question: when you say testing, what are you testing? What body samples are you testing? Are you also doing the nasopharyngeal swab, or you're doing an autopsy and looking at the pathological findings? And when you say your caseload has increased 10%, so you're saying that any case that is concerning for COVID, those cases are coming over to you as well?
Yes, so we have, I guess there's a lot of parts to that. We have had since early March, had our investigators who take most of the reports of death from hospitals, from police and other people. They have been completing a questionnaire with whoever's reporting the death to them regarding, early on it was recent travel, but since then we're focusing on, symptoms related to coronavirus infection, as well as exposure to known cases. And anybody that presents to us with a history of flu-like symptoms that would be concerning for coronavirus, whether or not they have history of exposure to anybody, we have been bringing those cases in and doing a full autopsy. Generally, most of the time we're doing those in our isolation room, where everybody's with respirators and full PPE. In the postmortem state, really, coronavirus is not really as much of an issue as it is certainly for emergency room docs and hospitalists and others that are dealing with people that are still coughing and breathing and other things. Our patients don't shed virus that way, but we do things to minimize aerosolization. For example, during removal of a brain and other things like that. Sometimes not, we won't remove a brain until we have the results. Just depends on the nature of it, but we're doing all of those known cases or suspected cases in our isolation room with minimal staff. So that's what we're testing. The testing that we are actually doing is nasopharyngeal swabs. We have a long history of doing nasopharyngeal swabs. We do, the film array testing that BioFire offers, looking at respiratory pathogens generally in cases where we have that concern. And that's something we've even published on before, but so we're very used to collecting the samples, and we just collect an extra set of swabs that are now being sent for that coronavirus testing that's being done at the state lab as well. And so we're not doing any antibody testing, and we're not at this point. There are immunohistochemical and in situ hybridization and other methods that are out there for diagnosing the disease in tissue, but we're not doing any of those. Really, our only resource for that would be the CDC pathology branch, and they will do that kind of thing, but they're kind of inundated with cases right now, especially from places that don't have the availability of nasopharyngeal testing in the postmortem state. So we haven't done any of that at this point, but that may still be an option. We may use that as a means of looking back at some cases before we started doing
When you look at all these cases and all these deaths from from coronavirus or COVID-19, have you noticed any similarities of comorbidities that may predispose to death from coronavirus? I'm sure that's a common thing that a lot of our patients would like to know.
Yeah, I mean, if there's some pretty good data on the state's coronavirus website, but looking at the mortality data overall, certainly, the vast majority of those dying are, over 65, and most of them also have, significant comorbidities, either immunosuppression of some type, or underlying pulmonary disease, or in some cases, that is asthma or COPD or whatever it might be. There's some pretty good information coming out that there's a number of other things going on here besides just the pulmonary component of this disease, and we have seen, at least in some of the autopsies we've done, thromboembolic disease, and that's being increasingly described as a marker or something that goes on with this as part of the disease process. So those are things that we've seen for sure.
So you had said, Dr. Christensen, you had said earlier that most of the cases were not coming to the office of the medical examiner for autopsy. What is the reason for that?
That is basically to conform with CDC recommendations to minimize autopsy in a case that has a diagnosis. If someone, and this is a pattern actually that we follow for many types of cases that we have jurisdiction over. For example, if someone is involved in a car crash, sustains a bunch of injuries, survives for 4 or 5 days in the hospital, has multiple imaging studies, and the trauma surgeons or the trauma attendings are comfortable certifying the death as due to those injuries, it's still our case because it's a non-natural death, but we allow the attending physician to certify that death. And that's more or less the way we're approaching these cases as well. If someone has a well-established diagnosis, presentation with worsening respiratory symptoms, progressing to respiratory failure, and has a positive test, and they are comfortable certifying that death that way, then we're not, we're still reviewing the chart to go through and see what, make sure that what gets put on paper is, makes sense, but we haven't really run into issues where that hasn't happened. So.
You had mentioned earlier that you don't need to worry too much about aerosolization in a dead individual compared to someone who was living. Do you have issues with PPE?
We do not. We've got, as a routine part of what we do, because we deal with, tuberculosis, we deal with meningitis, we do other things, we use pretty much standard, contact precautions for all things. And we have the ability to use, full respiratory protection when we need to. We've got PAPRs and we've got N95s. Everybody in the office is fit tested that's involved in autopsy. So, and we've got plenty of supplies at this point, and we've got contingency plans in place to get backups if we need them.
Man, that sounds awesome. It would be nice to have that for all the physicians. I know that's not possible, but if that wasn't been the biggest challenge, what has been the biggest challenge for you guys in this pandemic so far?
Yeah, I mean, I think probably I would say the biggest challenge has been, keeping up with our routine caseload in the setting of this, additional, 1 to 2 cases every day that are coming in that weren't coming in. So, we're doing, 10% more exams than we were, and we already do 9 to 10 a day. And so it's just, the volume is taxing on the staff for sure. We have not had really any issues with storage. That's certainly been a concern that a lot of people have had, but thankfully in Utah, that's not been an issue that we've had. Other jurisdictions like New York City and other places have had huge issues with that, dealing with as many as, 1 to 200 deaths a day at some points during the pandemic there. And so, we haven't had those kind of volume issues, thankfully, but, we do have some contingencies in place to deal with that should we need to, but we thankfully have not really had much in the way of issues.
Yeah, we talk about flattening the curve, right?
Yeah.
And we hope that stays the same. As a professional opinion, do you think that it's possibly going to kind of have a resurgence here in the fall now that we're opening things up?
It's, I'm not an epidemiologist, but I hang around with enough of them working for the Department of Health that I think it's likely that that's going to be the case. But to what extent, I don't know, and whether that will require further interventions in terms of lockdown or other restrictions, I don't know. I'm not really in a position to say, but looking at the natural history of these things, it seems like that would not be a very surprising happening.
So, Dr. Christensen, how long does an autopsy usually take? I mean, and what are some of the cases that you see in the Office of the Medical Examiner, aside from the COVID-19 cases?
So, state law, the Utah Medical Examiner Act specifies what cases are reported to us. And for us, the bulk of what we do, it is any death that's unattended. So, somebody hasn't been to the doctor for 2 years. And, even if they had one that you could still contact, they really don't know what's going on with that person at that point. And then any deaths that are due to violence or injury. So car crashes, industrial accidents, workplace accidents, deaths of children, deaths that occur in the custody of police, and then suicides, drug overdoses, all the other, and then homicides and the things that you sort of more usually think of, and that makes up the bulk of what we spend our time doing. And then occasionally, we'll get other cases referred to us for confirmation. We've had a case not long ago of an individual that died from rabies. Did a case a couple of years ago, somebody that died from West Nile virus because the diagnosis at that point. And so anyway, there's things like that we also get involved in. And certainly a number of the natural deaths that we get involved in are just simply because people didn't know they had significant heart disease, for example, or they had significant lung disease but didn't expect to die from it when they did, and things of that nature. So that's the bulk of what we do. And like I said, that constitutes, last year was just over 3,350 cases that fell under our jurisdiction. We're on pace this year to, even excluding the coronavirus deaths, probably will hit 3,700.
So you do 3,700 autopsies or so, and how do we know then throughout the whole state of Utah, how do we know that the number of deaths attributed to coronavirus are accurate?
Yeah, it's a good question. It's one that actually seems to be coming up a lot lately. There's a number of things that go into it. Redundancy-wise, certainly there are epidemiologic definitions that the Department of Health uses to determine whether a case is coronavirus related or not. Part of that is, the right clinical course. Part of it is having a positive test. If someone has coronavirus listed on their death certificate, that is marked for inclusion. But as far as the deaths go, when a death is reported, from the hospital or anything else that is routinely reported to us, we've worked with the Office of Vital Records to make sure that any death that's certified that way, there's an alert in the online death registration system to contact our office so that we get it into our system for review. We have had, just from our own in-house testing, certainly had a number of cases that turned out to be positive, but their deaths were very clearly from something else, like injuries from a car accident and things like that. They just happened to be positive. So we review all of them, and in these, it seems pretty clear that most people, if they're having symptoms, are seeking out, some kind of treatment or at least a diagnosis. And we've had a number of cases where someone, had symptoms enough to be tested, were sent home because they weren't sick enough to be hospitalized. They subsequently died at home. Usually those cases we will also bring in, repeat the testing and see what's there, to just, assess, is the pathology that's here, is their death actually due to this, or is it something else? And we've had, in the setting of workplace clusters and other things, there's a lot of concern anytime, a coworker tests positive and then subsequently ends up dying. And those, we review all of those. Anybody that doesn't have a diagnosis, like I said, but is having those kind of, symptoms, are going to be referred to us, and we will, even though we might, under normal circumstances, bring them into the office, we are doing that now. So if somebody dies at home and does not have a physician to certify their death, then we're the ones that do that. So we're making sure we review those as well and test them as needed.
So based on the Utah, the health department's website, we've had how many? At least 80 deaths. Can we assume that, or is it right to assume that all these deaths were positive by nasopharyngeal swab for the PCR? Or do we have
Yes.
any that are clinical? Okay.
Yeah, no, that I know certainly in other states that's been a big issue where people, there just has not been the capacity or the infrastructure to try and get at every death with testing, like we are trying to do here. And I know the guidelines from the National Center for Health Statistics allow physicians to certify death as probable COVID related if they have appropriate exposure, if they have an appropriate clinical course, but just had no testing. And so that is being used in some places, but none of the deaths reported in Utah fall into that rubric.
Now, being a clinical pathologist, this is kind of my purview of the things. I am interested to know if we still have, and I know we're still working on this, but I wanted to know if we've gotten to an acceptable level where we've reached a good, positive or negative predictive value for these tests.
I know that there are some are very good, some are really not very good. I mean, there's been a lot in the press about that. I don't know the specifics of it. I do know that, ARUP has developed a test in conjunction with some big lab, and I can't remember who, but the testing on that shows that the sensitivity and specificity are both well above 99%. So, some of those antibody tests at least are very good. I mean, there's no question with the PCR testing, the nasal swabs that are being done, depending on when you test someone in the time course of their disease, they may or may not be positive. Early on, they may not be, then they'll be positive for a while. And as their disease progresses, especially in those that get really sick, a lot of times they'll test negative. And it's hard to know exactly what a negative test means if that's your only testing medium. And like I said, we're not doing any backup antibody testing in any of our cases at this point. We routinely save samples on cases, and that may be something we could do as a retrospective look at some point.
It's a good idea. That might be worth doing sometime in the future.
Yeah. Mm-hmm.
Now, I wanted to sort of venture into the unknown for me. What kind of specific or vague pathological changes have you seen under the microscope with coronavirus? Or, and this could be a question to take us all back to medical school.
Yeah. Yeah. So, the lung generally sort of has limited responses to insult. And like many things, the final common pathway for a lot of things is diffuse alveolar damage, which is, the pathologic correlate of adult respiratory distress syndrome. And that is, the most commonly described pathology in coronavirus deaths. And what you see there is, you see hyaline membranes throughout the lungs, you see revved up pneumocytes throughout the lungs, fibrin. And one of the things that's a little more unique to this condition is that you see fibrin thrombi, not just in the lungs, but other places as well. Microthrombi, microvascular disease. And there's a because this, I guess the receptor for this virus is the ACE receptor, that there is increasing evidence that in addition to being in the lung, there's also extensive endothelial expression of that receptor that is associated with endothelial injury, leading to this, microvascular thrombotic disease, which is causing some problems, in pretty much all organ systems. There's a report that's just out of Mount Sinai in New York, looking at a case series of, I think, 67 autopsies, where they looked at a number of, actually a pretty extensive study, looking at a variety of things, including clinical correlates and inflammatory markers and other things. And that was a recurring finding. In addition to really high elevations of some of the cytokines, interleukin 6 and 8, and human necrosis factor alpha are all pretty elevated in these patients as well. The findings we see at autopsy are fairly non-specific that way. I mean, the type of ARDS picture, diffuse alveolar damage picture that we see in these patients really is not drastically different than what we were seeing in some of the E-Valley cases, the vaping-related lung injury cases. They're not really different from what you see in someone who develops ARDS from being on a ventilator, either associated with pneumonia, from chemical insult. I mean, all those things. Your lungs just kind of don't have a lot of ways they can respond, and what they do is develop this kind of ARDS picture.
So, Dr. Christensen, a couple of questions. For instance, when you have a biopsy done, let's say intestinal biopsy, I know they can do some viral PCR studies on it, like a CMV PCR. Have you heard of anything being a PCR being done on some of your your tissue specimens? And have you by any chance noticed any typical cytopathogenic changes specific to this virus, or it's too early to tell?
Yeah, I mean, I personally have not seen that other than just the routine lung insult. But like I said, the studies that are out there was an autopsy series out of China. There's a more recent one out of New York City. And others, the one thing that they're finding is not necessarily organ specific, but it is in the sense that it's vascular system, that there's endothelial damage that causes and as you see in the news, you hear these reports of people's courses, and some of them are just so widely disparate, and part of that is explained by the fact that that microvascular injury can manifest in any organ system. The most recent series out of Mount Sinai talks about microinfarcts in the brain, changes in the gut, changes in the lungs, changes in the heart. And so, depending on where that insult occurs, is going to be, make a difference in terms of what the clinical presentation.
It's a good point. And I think it's something for us to keep in mind as well. Now, I guess we're coming up pretty close here on our half hour, but I was wondering if you could share maybe a memorable experience that you've had, or about a COVID-19 case that you've seen so far.
Yeah, like I said, most of them we're not seeing. So from that standpoint, they're not memorable in the sense we're not doing those exams. But the most recent one was not one that I did, but one that one of my colleagues did. And just the degree of lung injury that's there in such a short time course is really pretty impressive. It's kind of like I said, mentioned before, the E-Valley comparison, but that the development of ARDS happening so quickly, and people that are seemingly well, the clinical histories that we review in these cases, really pretty pronounced how some of them are. I guess the hypoxia that they're experiencing without having the usual symptoms that might go along with a saturation of 60%, I guess, is kind of striking to me. Pathologically, the lung pathology is certainly the most notable thing in the cases we've seen so far.
For me, it seems I just did a recent study on vaping associated lung injury as well. Mm-hmm. And the pathology that I saw was, it's exactly what you described, very nondescript, very just general diffuse alveolar damage, very high mm-hmm. membranes. And, but this was on mice too. And these mice weren't struggling. They weren't suffering. There was no real sign no clinical sign that we could have that they were actually respiratory, they were compromised with a respiratory system. Right. And so I wonder if that's kind of the same thing that's going along with humans for for eVolley, and then also with this coronavirus thing as well.
Yeah, it could well be. I mean, that's one thing that's striking looking at, any lungs with DAD. You look at them and they're like solid, and you're like, how could any air exchange be happening here? But clearly it was right up until the time they died. And it's just that, to me, it's just always remarkable how much reserve your body has, I guess, to deal with insult before it finally gives in and says, I can't do this anymore.
So, question, non-COVID related. How can we, other physicians, make the life of the medical examiner easier?
Don't hesitate to call us. That's if you've got any case that you think is remotely related to a non-natural cause, don't hesitate to call our office. If you feel like you're not getting, the information you need, or not able to convey the information you need through our investigators, they're usually pretty good at that. But if not, one of the docs in the office is always on call. You can always ask to talk to us, and we're happy to, answer whatever questions you have or try and address your concerns. I mean, there's no question that, a lot of, because we do this every day and we have a good sense of how we do things and whatever else. And for most physicians that, have a death that falls under our jurisdiction, unless you're a hospice doc or something else, it's probably not something you're going to encounter more than, a few times at most during your career. And so we don't really expect you to have, a full working knowledge of, how we do things or what's appropriate for us to examine and what's not. But, we're always happy to have that discussion. So, I guess that's the main message I would say. Don't hesitate to call us.
Dr. Christensen, thank you so much for being here with us today. We truly do appreciate you and your insight, especially, as physicians, most of us see things on the living end of the spectrum, and we're very grateful to see your perspective from the autopsy end of the spectrum.
Yeah.
So really do appreciate that. And so thank you again for your work.
Well, thank you for having me. Glad to be here.
Thank you. And hope to see you next year.
Yep, that would be great. Thank you.
Thank you.
Thank you. Your producers for this program were Clark Madsen, MD, Teresa Puskedra, MPC, and the Board of Directors for Ogden Surgical-Medical Society. The Executive Director is Teresa Puskedra, MPC. Your host was me, Scott Moore, DO, and Petronella Adomako, MD. The editing and sound design was by Colton Gomez. This was all made possible by supporting members of the Ogden Surgical-Medical Society like you.